today to talk to Dr. Erin Perucci, an OB-GYN with Inova. She's a Menopause Society certified practitioner and the chair of Obstetrics and Gynecology at Inova Fair Oaks Hospital. Thank you so much for being with us today.
Thanks for having me.
So give us a little bit about your background as a physician and how you got interested in menopause.
Yeah, so I've been practicing in the Northern Virginia area since 2012 when I graduated residency and came back home because I'm a lifelong Northern Virginian. Um, I found that my patients were growing up with me and asking me questions that I didn't have the knowledge to answer. Um, And so that's really how I started my own educational journey on learning about menopause, learning about the new data since the Women's Health Initiative study 25 odd years ago. It really opened my eyes to a whole, part of OB-GYN that we hadn't really been trained on, but was something that women that were aging and coming into midlife and menopause, really needed and were denied for a long time.
It does feel like there is a certain wave of support and interest and a hunger from women to have this information. What has long been sort of dismissed as just part of aging or just deal with that or your symptoms may not even be real. Now people are paying attention and there's a greater appreciation for all the changes a woman's body goes through, when they're getting into those, late 40s, early 50s. Tell us about what that looks like and what you're seeing in your patients from a symptomatic perspective.
Yeah, so it really can be widely varied. I mean, of course, you're getting the most classic symptom, the vasomotor symptoms, hot flashes, night sweating, up to 80% of women are going to experience that. But I get a lot of complaints about brain fog and cognition issues. Sleep disturbances are huge. Joint aches and pains or feeling stiff. A patient told me recently she felt like the Tin Man and she needed to be oiled. Um,
That's a great description.
I think, women are still out in the workforce wanting to be active. They're moms, they need to be present, and they're finding that all these little symptoms are really impacting their day-to-day functioning.
That makes sense. And so it's great that there's more attention on it now. There you were talking, part of your intro was, certification in menopause society from the Menopause Society. Tell us about that. Is the Menopause Society a new thing? Is that something that a certification is just recently available, or is it just more people are taking an interest in doing it now?
Yeah, no, the Menopause Society has been around for a while, and it's kind of our, preeminent governing body when it comes to putting out recommendations for menopause care. And they've, I think it's a renewed interest in becoming a certified practitioner so that patients know if they're coming to you, they're getting, knowledge that is based in science and based in fact. Whereas there's a lot of ability to obtain treatments, out in the community that may not be based in that.
Yeah, I mean, I think there's a lot just from sort of my own social circles. I see and hear a lot about people pursuing, different supplements that they see online, like, oh, creatine, I have to have creatine now, or all these different magnesium choices. And it's hard to know like what the right mix is and not find yourself in a position of having to take like 10 different supplements over the course of a day. When you're seeing a patient for the first time, how do you sort of approach their care? Do you start with labs? Obviously you start by understanding what symptoms they're having, but, talk to me about how you kind of think about that.
Yeah, so always first I'm looking at what's their age, what's their medical history. Looking for any big red flags that would direct me in a certain way in terms of what treatments would be medically appropriate. That's knowledge I want to get before I even go into the room. And then I first sit down and say to the patient, tell me why you're here.
Mhm.
Tell me what's bothering you so that they can really just lay it out. And then that lets me know too, okay, what is going to be a goal of treatment? What kind of things are bothering them? Because really, again, it's not one size fits all. And there may be different things that patients feel is the most important thing to them.
Mhm.
Um, and then
Yeah, like maybe some of those symptoms go away if you're sleeping through the night.
exactly. Yeah. And so we really look at that. And then, we look at what would fit into someone's lifestyle the best
Mm.
because there's lots of different options out there. I think, that was a downfall of some of clinicians that were in the past trying to treat menopause. They didn't know about everything that was out there to treat it. So they kind of approached it like, here, take this pill. That's the only option there is. And so we look at that and try to find the best regimen. I'm also really honest with patients that there's no magic bullet for everything,
Yeah,
and nothing's without side effects and risk, and we talk about all of that.
that's great. And so, talk a little bit more about like what's the difference between perimenopause and actual menopause, and how does a woman sort of assess which stage they're in?
So menopause is the absence of periods for 12 consecutive months.
Okay.
And there's really not any one lab test necessarily that can determine menopause and perimenopause. These are what we call clinical diagnoses.
Mhm.
And so absence of periods for 12 months, that makes you menopausal. If you don't have a uterus, so you don't have periods, then sometimes we use lab work to look at certain levels to see are they elevated, and that can give us an idea. But again, not always necessary in a certain age of a patient.
Mhm.
We are going to treat that patient's symptoms really no matter what the lab says. And then perimenopause, that's actually a diagnosis that or a term that we use a lot and we hear on social media and people use. It really refers to the time before the last menstrual period and even incorporating the 12 months after. So peri means around menopause. So perimenopause and the transition into menopause really starts with um cycles becoming irregular. So menstrual irregularities where you see plus or minus 7 to 10 days or so in variation of cycle length. And that's happening in more than just one cycle. And then that starts to tell us, okay, you're probably entering into the transition into menopause. And then once you're going 60 days or more with no period, that signals the late transition where probably your last period's going to be in the next 2 to 3 years.
Okay.
So that's kind of where we look at it. Now, if someone is having regular periods and they have not seen any of these um, irregularities yet, can they still be starting to come into that transition? Yes, they would be termed. They wouldn't be perimenopausal yet, or in the menopause transition, they would still be what we call late reproductive stage, but they can still have symptoms. There's not like a demarcation line,
Right.
and so sometimes we are using menopausal hormone therapy in those younger women or patients that still have regular cycles to tackle symptoms.
So you talked a little bit about some of the symptoms. What symptoms do you feel like tend to get overlooked either by the patient or by physicians and maybe attributed to aging or stress or other things?
There's so much overlap
There is,
between,
yes.
what might just be, normal stuff that's happening because of whatever's going in your life, that kind of thing. Sleep disturbances, mood changes, sometimes like heart palpitations and things like that. Patients again attribute a lot to stress. That kind of stuff sometimes, until a patient gets to a breaking point a lot of times kinda gets poo-pooed,
Mhm.
especially too if they're not having those menstrual irregularities, so they're not necessarily putting 2 and 2 together.
Right, okay, it's not getting connected
Mhm.
then. And what are, talk you mentioned hormone therapy a minute ago. I wanna talk about that, but maybe talk about first sort of the range of treatments that you do for different people.
Yeah, there is so much out there from lifestyle modifications, optimizing your weight, your exercise, your sleep, non-hormonal treatments. We can use some of our medicines that we commonly use to treat mood disorders,
Mhm.
to treat vasomotor symptoms. Sometimes things like gabapentin that treat pain and things like that can treat symptoms of menopause. We also have some newer medications on the market, notably the neurokinin 3 receptor antagonists, which actually target the receptor in the brain that has to do with regulating your temperature. Those also a newer medicine in that family that has just come on the market also helps to improve sleep. So we've got a lot of options even outside hormone therapy. So patients who a lot of times previously thought there was no options for them, there are lots of options. And I often too, some of those non-hormonal things we're going to even use in patients who are using hormone therapy to
Right.
help really optimize things.
How much are you going sort of the medication route versus also looking at supplements like the magnesium, the creatine, B12, etcetera? Are you usually doing a mix? Are you kind of going down one path? I feel like there's a lot of social media content that's like, here's all the supplements I take. And a lot of times it's sponsored. There's an ulterior motive, obviously, by
Right.
whoever's pushing out how wonderful it is. But I do think that leads to a lot of patients not having a clear view of how they should be seeking treatment.
I am not a huge, huge supplement person because the supplement industry isn't regulated by the FDA. So, you can take a magnesium supplement, but are you really getting what it says on the bottle? Well, nobody really knows
No one.
because, this is not regulated. And so they can sometimes be a nice adjunct, but the mainstay of treatment for most healthy women for menopausal symptoms is going to be, therapy with the hormones,
Mhm.
or these other treatments that have data behind them. Um, but that being said, yes, I mean, I will say I want patients to get their nutrition from the food they eat.
Right.
So we talk a lot about optimizing nutrition, utilizing our awesome support services at Inova through, dietitians we have available. We have someone who really is interested in menopause and midlife. She probably, I don't know if she hates me yet that I send so many people to
I
her.
have to get that name.
And I want people to be eating right, practicing good sleep hygiene, exercising, and really, supplements can be a nice little added benefit.
That's
Yeah.
helpful. That's really helpful. And so let's talk a little bit more about hormone therapy because
Mhm.
I know for reasons I don't necessarily know, maybe you can shed some light. Hormone therapy seems like it's had controversy over the years, or people think it's linked to, an increased risk of cancer or, different things like that. Tell me what's true about hormone therapy.
So, hormone therapy was more widely used than it is today in, the 70s, 80s, 90s. Um, a study came out in the early 2000s called the Women's Health Initiative Study, that had several different arms, but one arm of the study that looked at women taking estrogen and progesterone together, was stopped early because of perceived risks. And that was risk of uh, blood clotting and cardiovascular disease, and then risk of breast cancer.
Mhm.
The risk was not framed appropriately to the public in terms of how great that risk was.
Okay.
And even the
Potentially overstated.
Right, overstated, that's
Mhm.
yeah. And, even the study investigators have come out and said, "Yes, we did not present that to the public correctly,
Mhm.
and we caused alarm that really probably wasn't warranted."
Mhm.
Many people don't know that the arm of the study that looked at estrogen only in women without a uterus continued for several years and did not find any increased risk of breast cancer.
Interesting.
Um,
Okay.
yeah, that wasn't publicized.
Right.
And so it really made the pendulum swing totally in one
People got scared.
direction, that everybody got scared. Even physicians got scared, even though the study had some design flaws. Average age of the woman in the study was in her early 60s. It really wasn't the population we
Mhm.
give hormone therapy to, because timing of when we start that matters. It used hormones that are generally not the, regimen that we start with, and that is our preferred regimen, so there was a lot of flaws in that study. And data has come out since, but for some reason, medical education, residency education for OB-GYNs, just general physician knowledge never kept up.
Okay.
And women were just told, "No, this is dangerous, this is not safe, this is going to give you a blood clot and breast cancer," which is not yes, are there still risks associated? Absolutely, but for most healthy women in the right age, the right time frame, those risks are small and acceptable.
And I feel like some of those risks have even been associated with being on birth control in your,
Agreed. Yeah, they are. Mhm.
and many people take that because the risks are so minimal compared to the benefits.
Exactly.
And so maybe a similar sort of view on this as well.
Yes, that the risks for most there are some women who, because of certain health conditions, we say you can't use birth control because it's going to increase risk of a blood clot or something like
Right.
that too high. Um, it is the same for hormone therapy. that there are definitely populations that it's not appropriate for. And I think that's why it's important to see a clinician who understands how to look at someone's medical history and know which populations those are.
So when you do have a woman that you're like, this is suitable for you, this is an appropriate treatment for you. Tell me what kinda is it a pill, a daily pill? How do they take it? And how does like, what are the benefits they start seeing from it?
Yeah, so we have lots of different formulations. We have formulations that are absorbed through the skin, formulations that are taken orally, and formulations that are absorbed through the vagina,
Mhm.
which also are like absorbed directly into the bloodstream. For most women, we try to start with those regimens that are absorbed directly through the skin or the vagina into the bloodstream. They don't appear to increase your risk of a blood clot, heart attack, or stroke. Oral preparations, like a birth control pill too, have to be metabolized by the liver. They're thought to increase liver clotting factors and thus give us that small increased risk there.
Okay.
So if we can start with transdermal, we like to, but doesn't mean the other stuff is,
It's not ever
is not
appropriate.
ever appropriate for somebody. So lots of different things, and that's why I talk to patients about what's gonna fit into your life the best. If you can't put on a Band-Aid without getting real bad irritation, then a patch isn't for you. And,
Right, right.
we're gonna talk about that. Um, there's also, again, we go over all the other options too, outside of using hormone therapy, that might be appropriate, and different hormone therapy that we use to treat different conditions in menopause. So there's systemic symptoms and there's vaginal symptoms, and they're
Mhm.
treated differently. Um, some benefits that patients are going to see is symptom relief, usually very quickly. And still, we're using this. We can talk a little bit about the health benefits of HRT, but still, the recommendation is for symptom relief. And they're going to see ideally about a 60 to 80% reduction in their symptoms in that first 6-week period.
That's considerable.
Yeah. They start to notice it right away.
Right away, yeah.
And then one thing we do know that hormone therapy can do is protect your bones
Mhm.
and is gonna, help prevent some of that bone loss that happens rapidly after the loss period.
Oh, wow, and that's so important as you get older, keeping that strength and the muscle and all of that too. Um, that's really good to know. What would you say, at what point should someone seek care when, because there's a lot of times I think women, to your point, busy, they might be working, they might be moms, they might be taking care of parents.
Mhm.
It's hard to kind of find time to get see your doctor. But at what point should you stop powering through the symptoms and really say, like, okay, it's time to talk to a doctor about this and get some medical intervention?
Yeah. Of course, if really severe symptoms, heart palpitations, chest pain, very bad, irregular, heavy bleeding. Sometimes that happens in that, transition into menopause. We don't want people to be doing that, unchecked. Mood symptoms that are just out of proportion with what's normal, suicidality, things like that. You should always see your clinician right away. And those should be investigated. But I mean, I feel like, because I definitely get patients that come in and they're like, "Well, do I need this?" And I say, "Well,
You tell me.
are you functioning?" And everyone's, how it impacts someone will be different. I've definitely had patients who say, "I have a couple, I have hot flashes, but they don't really impact my day to day, so I'm okay with them." All
Mhm.
right, fine. But if someone's like, "I cannot be in this meeting," and start to tear up or all of a sudden be covered in sweat, it's impacting my work. It's impacting my ability to function. I haven't had a good night's sleep in, months. It's time to talk about that.
Yeah, get an
Yeah.
intervention. Life can be better.
Absolutely, yeah, and I think women are just used to taking care of everybody else, and so I definitely have patients that say, "I should have been in here 6 months ago. I should have been in here last year. This has been going on for a long time."
I'm sure they do because once they get the relief through whatever regimen
Yeah.
you give them, they feel so much better. They're like, "Oh, why did I wait?" I mean, I feel like that's true for so many healthcare things.
Yeah,
It's like, "Why did I wait? This could have been better faster."
absolutely.
What haven't I asked you that you would want our listeners to know and understand about menopause?
That it shouldn't be expensive to be treated. So if you're going to see a clinician and you're having to pay a lot of money to see them, to have lab work done, to buy what they're selling, then, you know, that is not, in my mind, ethical.
Mhm.
And you should be seeking out a clinician that is using FDA approved medications, that will be covered by your insurance, and ideally that has the certification and the knowledge to not only prescribe all these things, but troubleshoot them, tweak them as needed, change them if needed. So seeking out a someone who is Menopause Society certified is ideal. Um, Additionally, nothing works alone. There's no like I said, there's no magic bullet. So we always have to do the work with optimizing our lifestyle and, making sure that our sleep hygiene's good so our sleep can be good, and making sure that we're reducing stress levels and making exercise part of our daily regimen because all of those things are gonna enhance treating these symptoms.
That makes a lot of sense.
Yeah.
Dr. Perucci, thank you so much for being with us today. This is great information.
Thank you for having me.